it, but I'll just go over from basics to the management, and please feel free to stop anywhere and discuss any aspects. This is the outline that I wanted to go over with. First, we talked about the pericardium, anatomy, physiology, then particularly regarding cardiac tamponade, etiology, pathophysiology, clinical features, diagnosis, management, and then we'll have some take-home summary points. So pericardial anatomy, as we know, it's actually composed of two layers. One is the parietal pericardium, and the other one is the visceral pericardium. The parietal pericardium is the outer pericardium. It is the fibrous structure, which pretty much contains the pericardial fluid. So the very fact that we have pericardial effusion, pericardial tamponade, is that the parietal pericardium is pretty fibrous and stiff. I mean, it can retain, against the pressures of the intracardiac cavity. So even if the pressures in the ventricle are about 140, it can still hold that pressure. So that's a pretty fibrous structure. It's about 2 millimeters in thickness. And you have the visceral pericardium, which is a very thin, pliable membrane, which is adherent to the epicardial surface of the myocardium. So it's very difficult to distinguish the visceral pericardium from the myocardium. Most of the places it's adherent, and there are the epicardial vessels. So what we're concerned when we talk about the pericardium, we always talk about the parietal pericardium. And the space in between these two is the pericardial cavity. Okay, and the pericardial cavity or the pericardial space. Normally, it has many functions which have been hypothesized. We don't know exactly what it does, but it does primarily decrease the friction every time the heart beats because of the fluid, and that's the way our body is made. Every joint, everywhere where we have movement, we have cushioning or lubricating areas, a cavity with fluid-filled area. So we have the pericardial fluid for decreasing the friction while the heart beats. So when the heart squeezes, the visceral pericardium moves with it, and the parietal pericardium stays that way. Generally, that's how it works. And then obviously, if there is any infection in the mediastinal cavity, the parietal pericardium kind of holds it from going on inside the heart. And it contains about 20 to 30 cc of lymphoid fluid. If you look at it, the surface area of the heart is pretty large. 20 to 30 cc will get distributed so evenly that you generally, on the echocardiogram, you hardly see any space, unless and until there is some pericardial fat. If there is pericardial fat, which correlates with people being obese, there's a lot of body fat, or having some weird diseases. But still, except in those conditions, you cannot separate the parietal pericardium from the visceral pericardium. So if you have a transthoracic echocardiogram, if you see a space between the parietal and visceral pericardium, it's unlikely to be a normal fluid. Okay. Unlikely to be, if you're seeing it already. And if it is more than a couple millimeters, then it's definitely more than a 20 to 30 cc. A normal pericardium can stretch and accommodate. It is, even though it is a fibrous structure, it can accommodate, but it takes time to get accommodated. And we'll talk about it a little more in detail. Excuse me. If you look at the etiology, anything can cause pericardial effusion. Coming back to the definition of pericardial tamponade, now pericardial tamponade is, there is pericardial effusion. Some of the pericardial effusions can cause pericardial tamponade. So pericardial tamponade is a phenomenon in pericardial effusion. Okay. Now, what percentage of pericardial effusion cause pericardial tamponade? It's a very small percentage. People have asymptomatic pericardial effusion all the time. If you have any of the rheumatological conditions, they have chronic pericardial effusion all the time with no clinical significance whatsoever. Clinically, it becomes important only when it becomes big enough that it impedes the contraction of the heart. So pericardial tamponade is a small fraction of all the pericardial effusions. Now, this is talking in general. When it comes to post-procedural patients, any effusion, there is no reason for the effusion to be there. The odds of it being a coincidental finding is very low. On the other hand, if you see an outpatient, 25-year-old patient with SLE, and you do an echocardiogram and you see a 1 centimeter thick pericardial fluid, there is a pericardial effusion which is small to moderate size. But the odds of that causing tamponade is very low because it's a clinical coincidental finding. So these are the most common causes of pericardial tamponade. So you can have acute pericarditis because of viral, bacterial, fungal parasitic. All these things can cause pericardial tamponade. But again, the percentage is low. Many people have pericarditis and not have pericardial tamponade. It's about 14%. So 14% of the people who have acute pericarditis actually have clinically significant pericardial effusion to cause tamponade. That is actually a low number compared to bacterial, not bacterial, but acute pericarditis. If you see these syndromes, all the rheumatologists, this is a very common cause of pericardial effusions. Again, most of these people have pericardial effusions chronically and not have tamponade, but sometimes they have tamponade. What we are actually the most common cause of pericardial tamponade are neoplastic, people having cancer. That's the most common cause, because any cancer, if it goes to the pericardium, it causes effusion. It goes to the myocardium, it causes effusion. If it goes to the pericardium, it causes effusion, and because most of the time it's metastatic, it doesn't reverse and it keeps collecting and tamponade sometimes. So in general cardiology, if you see, the most common cause is neoplastic. Okay, and what we are concerned about are these post-procedural, after sternotomy, after a CABG, interventional cardiology procedures. If it's EP or interventional, it doesn't matter, but very common. Acute aortic dissection, and these are the ones which we see more commonly. I'll go over in detail, actually a little more in detail. If you see the cardiac procedure, I thought this may be more pertinent to our day-to-day practice. So any patient who undergoes transeptal puncture, there's a 1 to 2% chance of having a pericardial tamponade, not an effusion. Okay. Again, I have to say this, that the odds of someone having an effusion and not causing tamponade is low in this patient population, because if they have an effusion, likely there is a perforation. That's why they're having an effusion. There's no reason to have an effusion. It's not an inflammatory effusion. They do have it, but the odds are low. So most of the people who have an effusion will eventually have tamponade, compared to general population, where if 100 people have effusion, only 5% of the patients will have tamponade. So here it's we don't know the numbers, but it's much higher than that. It's probably 50-60%. So anyone who undergoes a transeptal puncture, odds is high for obviously a couple of reasons. One is doing the procedure, you can perforate. Second is anticoagulation. Every time you go to the left atrium, you giving them heparin, and so that's one. AFib ablation. No matter what we say, the initial experience was about 6%. So this is worldwide experience till 2005. From 2005 to 2010, the recent studies were 1 to 3%. Our experience of AFib ablation in our center is less than 1%. I was looking at it this weekend. We had 700 AFib ablations over the last 5-6 years, and large pericardial effusions requiring TAP were about 5, so it's less than 1. But 25% of all post-procedural deaths after AFib ablation are pericardial tamponades. So most common cause of post-procedural death is pericardial tamponade. So that's still an important part. Device implants, again, this is general population. Not our center, but everywhere. It's 1 to 2%. It's probably overrated. It's not this high. But if you include BIVs, ICDs, and pacemakers, probably may be true. BIVs more likely because you put more leads and you go into the coronary sinus. ICDs more likely because they're stiffer leads, and pacemakers. Obviously, if you have dual chamber, more likely than the single chamber. More likely atrial perforation than the ventricular perforation. And this population actually stays good for any pericardial effusion and tamponades. Okay, elderly more likely because more friable. The compliance of the pericardium is also low. We'll talk about it. Women more likely to have steroids. Anyone who's on steroids, chronic steroids. I'm talking about chronic steroids. The COPD patients, 5 milligrams of prednisone taking for years. They're always at much higher risk. In fact, the risk is sometimes 20%. Some studies between 20 times, not 20%, 20 times more likely to have tamponade from any interventional cardiac procedures. Let it be CABG, let it be ablation, or lariats, or lead extractions. Again, 1 to 2%. You always have it. Fortunately, most of the lead extraction tamponades happen during the procedure, so we can recognize and fix it. but there are delayed tamponades. What concerns the most are the delayed tamponades. You know, whenever anything is acute, it's easily fixable. The delayed ones are the ones which become an issue in the clinic. So coronary interventions. This is by far the most common procedure, and approximately the percentage is low. 0.1 to 0.3% of all coronary interventions actually have a pericardial tamponade. Percentage is low, but you can easily identify the high-risk patients where whenever they use something extra, rotational atherectomy, chronic total occlusions, bifurcation lesions. So you know if the procedure is already being complicated, then you have a very low threshold to suspect this. Most of the time, I mean, half the time it presents immediately during the procedure. Again, if it happens, it's a bad sign. But delayed presentation happens about post-CABG, about 1%. Yeah, about 1% of all post-CABG patients have this thing. So what exactly happens in tamponade? There is accumulation of fluid in the pericardium in an amount sufficient to cause impaired filling of the ventricles. I mean, it is basically a battle between the pericardial fluid and the intracavitary fluid. So there is a pressure balance, and it's a tough war between both of them. Whichever has higher pressure wins. The primary driver is the difference between the pericardial pressure and the intracardiac pressure. Now when I say intracardiac pressures, different chambers have different pressures. So that's why different chambers are vulnerable to the pericardial pressures to different degree. So even though the pericardial pressure is equally applied, which is circumferential most of the times, the thin wall atria and the right ventricle appear to be more affected, obviously, because the pressures in the RV are probably 10 to 20. RA is about 3 to 10, and LA is about 5 to 12. The pressures are low compared to LV, where it is 20 to 120. This I'll show you a graph. Will be easier to understand, but basically it's a last drop phenomenon in the sense when there is accumulation of fluid in the pericardium actually stretches to a certain extent and it's compliant and accommodates some fluid without an increase in the pressure. But there comes to a point when it reaches the maximum distension. At that point, even 10 cc, literally 10 cc of extra fluid in the pericardium can cause shock and cardiogenic shock and so the last drop phenomenon. So I'll show you the graph, but basically it means that the final incremental addition produces a critical cardiac compression, and the first decrement during the drainage produces the largest relative decompression. So every time someone goes for a pericardial tab, you always see that they took out the first time they took out 50 cc, the blood pressure improved dramatically. I mean that's the classic finding we always have, and if they take out only 100 cc, doesn't mean that that's not a bad tamponade. It's still a bad tamponade. In fact, if 100 cc was creating an issue, that's worse tamponade than 500 cc causing this thing. And we'll talk about it. So this is basically a normal pericardium, and there is pericardial effusion, and it's causing some compression on all the chambers. But obviously, the relative intracardiac pressures are going to determine how bad they're affected. I want to go over this graph. This is a critical graph, has too many lines, but I'll just go over them very. So the y-axis is pressure, any pressure. So it's pressure from 0 to 100 millimeters of mercury. This is the pericardial volume. You have basically 4 lines. This straight line is the right atrial pressure. This curve is the pericardial pressure, AP. This is the cardiac output and the mean arterial pressure. So in the process of accumulation of fluid in the pericardial cavity, once the fluid volume keeps increasing, so this is 50 cc at 100 cc, which is actually not a lot of volume, it's not a lot. At that point, the pericardial pressure has gone higher than the right atrial pressure, right? So there is going to be some right atrial compromise or filling impairment, and you start seeing a drop in the mean arterial pressure. Once the pericardial pressure goes high enough to compress the RV, it's overcome the RV pressure, then it takes a much steeper curve. And after that, the pericardial pressure, even with sliding, this is actually a lot of increase. Now, normally the curve is not this way, the curve is this way. The pericardial pressure goes high and the mean arterial pressure goes down. So there are different degrees of curve, and the slope is basically, it's a logarithmic scale. So it keeps diving down. Till here, if you have a pericardial effusion of if you call it a moderate pericardial effusion, you say, oh, it's a moderate pericardial effusion, you have 100 cc of fluid in the pericardial cavity, but the next 20 cc is enough for the patient to crash, and you don't have much time. So that's the steepness of this curve is the most critical part, which always causes a problem, and which is the most common cause why people die of pericardial tamponade. It's so easy to fix a tamponade. All you need is to put in a needle, but still people die in spite of all the tamponades. I mean, most of the tamponades happening in the hospital. So what happens exactly? So this is the physiology. The reason I want to go into the physiology because that will help us understand some clinical features too. So there are many other things which happen, but three primary things. One is a progressive change, one is a respiratory change, one is we need to understand acute and chronic accumulation. Progressive changes in venous return. So once the pericardial cavity keeps increasing, no matter what happens to the respirations, no matter what happens, there is a relative increase in the pericardial pressure, which is causing compression on the chambers of the heart to a different degree on different chambers, but eventually the venous return to the ventricles is decreasing gradually. Okay, it doesn't happen gradually, but overall it keeps decreasing in the same direction. So normally the filling in the ventricle happens during late. Actually, this is important if you're looking at the central venous pressures, CVP pressures. Normally the filling of the ventricle happens during filling in the heart normally happens during late systole and early diastole. It's the atrial filling, the venous return getting into the atria. But in tamponade, it shifts earlier because there is so much of backlog that all the filling happens much earlier than that. So instead of early diastole, it happens during systole. So as soon as the systole happens, there's a drop. The fluid comes and the blood comes cooling down into the right atrium, and then there's no more filling because the ventricle cannot accommodate anymore. And obviously, overall, what happens is eventually the venous return decreases. This is the critical part. We'll go over this in a little more detail in the next few slides. But there is a respiratory variation in the venous return. So this is a normal phenomenon, but that gets exaggerated during cardiac tamponade, and that's ventricular interdependence. These terms we'll go over that. And there is a concept of acute versus chronic tamponade physiology. We'll go over that too. So ventricular interdependence. I have a slide on that thing. Yeah. So during normal respirations, the way the lungs expand is basically the rib cage and the diaphragm pulls the lung open. The chest cavity is actually the negative intrathoracic pressure because of which the lungs expand. That negative intrathoracic pressure is conducted through the pericardium to the pericardium and the heart chambers too. So all the chambers of the heart have this negative impact of intrathoracic pressure during inspiration. But that is transmitted more to the right side of the heart than the left side of the heart because they're more compliant, right? The right atrium and the right ventricles are more compliant, have less intracardiac pressure, so they're more sensitive to changes in the pericardial pressure. So there's an inspiratory decline in the intrathoracic pressure, which is transmitted through the pericardium to the right side of the heart. As a result, the systemic venous return, which happens to come to the right side of the heart, increases with inspiration. So every time you inspire, there's a negative intra-pericardial pressure, which causes a negative pressure in the right atrium and the right ventricle, and there's more venous return into the heart, because venous return is actually coming from the right side of the heart. In cardiac tamponade, the rigid pericardium prevents the wall from expanding anymore. So the same phenomenon is happening, but the pericardium cannot accommodate more, and the distension of the right ventricle, because of the increased venous return, it cannot go out into the pericardium, so it pushes onto the interventricular septum, causing it to bulge to the left ventricle, thereby decreasing the LV filling. Okay, so this is a very critical part of it. So normally what happens is when there is a negative intrathoracic pressure, the right ventricle, there is more venous return to the right side of the heart, and the right ventricle expands to accommodate it. Most of the expansion happens towards the pericardium. In pericardial tamponade, because it cannot expand towards the pericardium, it transmits that positive pressure towards the LV and pushes it, causing LV filling abnormality. So LV is not filling well during cardiac tamponade because the right ventricle is trying to accommodate a lot of fluid and pushing on the LV. So So the LV filling is decreased during inspiration. That's the critical part. So diastolic filling of the LV is impaired during inspiration, which happens earlier than expiration. Eventually it happens during inspiration and expiration, but it happens more or first during inspiration. If we can catch this part during clinical care, we've done our job. So this is the interdependence. So if we go to inspiration, this is the right side of the heart, left side of the heart, looking from above or from the apex. So left atrium, left ventricle, right atrium, right ventricle. So during inspiration, there is negative intrathoracic pressures, and because of which there's an increased venous return to the right side of the heart. Right atrium and the right ventricle get more blood. That's why you have a bigger arrow. Because there is fluid entering the right ventricle much more than during expiration, and it cannot be pushed towards the pericardium. It pushes against the interventricular septum. See the septal bulge. That's one of the first things which happens during pericardial tamponade on the echocardiogram. The septum bulges towards the left ventricle during inspiration, because of which the LV filling is decreased. So left atrial to left ventricular flow is decreased. During expiration, the opposite happens, where the tamponade actually compresses the right ventricle and right atrium, and most of the flow is happening on the left side during that time. Okay, so the left ventricle, the mitral valve has a significantly increased flow during expiration, and it switches roles during inspiration. So during inspiration, there is increased right-sided flow. During expiration, there is increased left-sided flow. It comes to our clinical findings and the echocardiograph findings. So this is the same thing. I want to spend a little time on this so that everyone understands. Right heart filling, that is a tricuspid flow. During inspiration it is more, during expiration it is less. Okay? So this is with each beat. So these are two beats, E and A waves. So during inspiration it is low, during inspiration it is high, during expiration it is low. And we measure on the echo, we measure the difference in this pressure. It's 25% different. Okay? Less than 25% is considered normal. Mitral valve flow, during inspiration it is less, because obviously more is going towards the right side, and then during expiration it is more. Normal is about 10 to 15%. This number, forget about the numbers. We'll come to the numbers a little later. But I hope any questions on the ventricular interdependence. All right. So acute versus chronic tamponade. I mean, as I said, it's a fibrous structure. It has a compliance. The compliance is limited. So when there's rapid effusion, it fills it to a certain extent. After that, it cannot accommodate, and there's a very, as I mentioned, the steep, the last drop phenomenon. Few drops of pericardial fluid causes a critical increase in the pericardial pressure, and this increase in the pericardial pressure, which is the y-axis, is the cause for all the clinical syndrome of pericardial tamponade. If it's a slow effusion, the pericardium kind of stretches and stretches and stretches and stretches slowly to accommodate as much as it can. Over time, it also reaches its final point and then causes tamponade. So it's not uncommon, and that happens especially in people who have mixed edema, hypothyroidism. There's a lot of pericardial fluid accumulating for years. They have large pericardial effusion for years together, and all of a sudden one fine day, one sad day, they get that extra few drops of this thing and then go into tamponade. So, and then if you go back and check the echo, you say, oh, the effusion looks the same from 2 years ago. It looks the same. Why is they having it's just a few drops. You can't even decipher it on the echocardiogram. But the critical point is, don't go by the volume. If someone says that small pericardial effusion, that doesn't mean anything. Small, large, or moderate sized pericardial effusion don't mean anything. All you need to know is the amount of fluid in relation to the timing of accumulation. Okay. So when we are talking about our patients in CTR, CTI, post-procedural, or interventional EP procedure, this is what it is. This is not the case. So all you need is a very small volume. The time to reach critical thing is also very low. So if there's a small pericardial effusion, that's bad enough. That actually, most of the times we tap before we reach to the tamponade, because we know that if there is an effusion post-procedure, it's likely because of a perforation or something else. I mean, there is a perforation, something has happened. So there's no reason to wait for it to cause tamponade. And I know when we were doing general cardiology elsewhere, it's like we used to wait for it to accumulate and accumulate and accumulate and show signs of tamponade and then tap it. I don't think either approach is wrong, but the key is now we know that there is a perforation, so there's no reason to wait. You just tap it. Especially if you're on anticoagulants. So if it's an interventional procedure, you have Plavix, aspirin, things like that, and if it's AV ablation or any of the EP procedures, most of them are on anticoagulation.
If that's the case, how do you know how much fluid to remove?
Oh, you remove everything. Oh, removal of fluid is you remove everything.
Okay.
You can rarely remove too much. You cannot remove too much because all you need is 20 to 50 cc was the normal fluid which is there. So that fluid is so small that no matter how much you tap, there will be some still
remaining.
Left. So in fact, you always remove. You end up removing less than what you want. You can never do. And then that fluid is it's like this joint fluid. It's not a fluid which is there for years together. It's a fluid which is circulated all the time. It's produced. It's a lymphoid fluid. It's like blood flowing through, but the flow rate is so slow. There's some cells, the visceral pericardium secretes this fluid, and something else absorbs. The lymphatics absorb. So there's a secretion and absorption. So even if you take out, something is going to accumulate. You never take out too much. This is the same chronic and acute. I don't know. So this is the chronic effusion and the acute effusion. Looking at the different way, how much fluid you need to take out to have a dramatic change in the pericardial pressures. So this is the pericardial pressure on the y-axis and the volume removed. In acute pericardial effusion, which is this red one, even taking out probably 50, this is 50, this is 100. Taking out 100 cc, look at the drop in the pericardial pressure from 45 to 10, about 50 or 100 cc. In chronic pericardial effusion, you need to take out a lot of fluid here to get the same effect. So acute ones are very, very sensitive to fluid. And then actually, if you take out 200, that's the maximum you have in this series of patients. But that's the maximum they could have taken out, and by that time it's almost zero, so you cannot take out anymore. Here you can take out, see how much of pericardial fluid that patient had, like 1400 cc's to get to. Pathophysiology, everyone. So I think key is the ventricular interdependence and the last drop phenomenon and acute. The same thing, acute and chronic. The acute and chronic differences, that is the last drop phenomenon and the ventricular interdependence. These two are the critical aspects. Presentation, you cannot depend on this. No matter what it is, you just cannot depend on this. These may or may not be, if it's post-procedural patients, half the time they're groggy, you don't even know what's going on. But to say, you can have chest pain, tachypnea, dyspnea. These are the first and the most common symptoms. Chest pain because whatever they did with the pericardium will cause some irritation to the pericardial cavity. So, or if it is pericarditis related, you will have some kind of chest pain, pericardial chest pain. And then you can have tachypnea, dyspnea. JVD, this is another classic finding. But you need some time for the venous pressures to go up and become prominent. So if it is happening over a few days, like an acute pericarditis getting complicated to a pericardial effusion and pericardial tamponade, then you have significantly elevated JVD in the sense. People describe having venous pulsations in the external jugular, forehead, and scalp. So the external jugular and these veins, the scalp veins, they all get distended. They actually get distended during inspiration. So when the same phenomenon of ventricular interdependence. During inspiration, there's increased venous return, but the right ventricle can accommodate to a certain extent. After that, it keeps going up. So there's an inspiratory increase in the venous pressures. These things, you may not see them anymore post-procedure because you don't have enough time to find these changes. Everything happens over there. Heart sounds, this does happen. So but for that you need to have the serial monitoring. So you hear the patient and then you hear and then here you see a gradual change. Yes, that's sensitive too. Obviously, if you have tachycardia with classic hypotension, pulse paradoxes. So this is another critical part. We'll come to that next few slides. We need to check this thing more often, and because this is one of the earlier signs. In in chronic pericardial tamponade, this may not be as important because you have these signs. If it's post-procedure, we may need to rely on this more than the other things. Sometimes people have vagal-like response. This is the one which bothers me. So whenever but this happens when there's a perforation. So people have, there's vagal innervation to the pericardium, and whenever there is a perforation, there's a sudden bradycardia hypotension, which is the vagal response in relation to the perforation. It's nothing to do with the tamponade. But after that, the signs and symptoms of tamponade, happen. But that happens very rarely. There are two concepts which we need to know is a regional cardiac tamponade. Now, whatever we talked about is about circumferential cardiac tamponade. You can have localized or loculated pericardial effusions, especially if we are doing interventional EP procedures. When I say interventional, it's cardiac intervention, so it can be EP or interventional. When we're doing a transeptal puncture, we perforate the posterior wall. If the patient had a previous pericardial procedures done, like the lariat or cabbage or any open heart surgery, the pericardium is actually taken out in most patients. Or the pericardium is adhered, the pericardial cavity is adhered in multiple segments that there are pockets of patent pericardial cavity. In such patients, if there is a perforation, the fluid will not be circumferential. It will not be circumferential, it will be localized or loculated. This is what we call a loculated and cause regional pericardial tamponade. We clearly had patients where we did a transeptal puncture and we perforated the left atrial wall, and there is fluid accumulation behind the left atrium. But if you look at the transthoracic echocardiogram, there is nothing. It's clean. There is no pericardial fluid whatsoever. But that localized or loculated pericardial effusion was compressing the left atrium and actually caused clinical cardiac tamponade. So we had to tap that patient. In fact, it's so difficult to reach behind the left atrium. But these do happen, and not uncommon at all. What we have to see is if the patient has had a previous pericardial procedure. When I say pericardial procedure, it can be an open heart surgery where you open the pericardium, or percutaneous epicardial ablation, or lariat procedures, or any of these things. So if someone has entered the pericardium, then all bets are off, because the pericardial adhesions will be distorting the pericardial anatomy, that the fluid may not be circumferential. There is another concept of low pressure tamponade. It's a little difficult to perceive, but again, the reason I'm saying is that when these two conditions happen, these things are you can't even find them. You won't see them. Low pressure tamponade is that intracavitary. So it's all in relation to the pericardial pressure and the intracavitary pressure. When the intracavitary pressure is so low, then the pericardial pressure doesn't even have to be high enough. It just needs to be a little high, not very high. So if the intra, for example, we're talking about the pressures numbers wise, the right atrial pressure, as I said, will be around 2 to 10 millimeters of mercury. If the right atrial pressure is between two respiratory variations are between 2 and 4 millimeters of mercury, so the right atrial pressure is very low. The patient is either dehydrated, had hemorrhagic shock, or overdiuresis. For whatever reason, the right atrial pressure is not above 4 millimeters of mercury at any point of time during the cardiac cycle. In that patient, if the pericardial pressure is 7 millimeters of mercury, which is actually a normal pericardial pressure, you can still have a tamponade because it's all relative, right? So that's a low pressure tamponade. Those patients, you may not even see a big pericardial effusion. It may be a small pericardial effusion, and they may respond to fluids. You give a bunch of fluids, the intra-atrial pressure may increase and may overcome that pericardial pressure, and they may become better. But it all depends on the etiology of their low pressure, the etiology of their low right atrial pressure. If it's because of hypoproteinemia and other things, no matter how much fluid you give, it's not going to increase the pressure. So those are tricky situations. But if you find a pericardial effusion and you rule out everything and you think the right atrial pressure is low, you put a swan central venous pressure and it's still reading 3, 4, 5, then you have to have a high suspicion of this low pressure. It's a rarity, but it does happen. So pulsus paradoxus, 5 minutes on this, and then we go to the treatment. After this, it's pretty quick. So normally, as I mentioned, this is a normal phenomenon. During inspiration, the right-sided venous return increases, and the left side decreases, and the reverse happens during expiration. Okay? So during inspiration, because the right side increases and the left side decreases, so critically the blood pressure is dependent on the left side, right? So left ventricle output is the one which determines the aortic and the peripheral arterial pressure. So during inspiration, because the left-sided output decreases, there is a drop in the blood pressure in everyone. There is a drop in the blood pressure. That drop normally is not more than 10 to 12 millimeters of mercury. So let's say 10 millimeters of mercury. So there is an inspiratory fall in the systolic blood pressure of not more than 10 millimeters of mercury in a normal person. In pulsus paradoxus, there is an abnormally large decrease in systolic blood pressure. In the sense, during inspiration, there is more than 10 millimeters of mercury drop. So it's not reversing; it's just exaggeration of the normal phenomenon. It's common. It's very common. Actually, more common than what we think. Even you don't even have to have a big tamponade. I mean, classic tamponade. Even earlier than that, moderate to severe tamponade you can have. These are relative terms. There is no classification like that. And it's a consequence of the ventricular interdependence. That's why I was talking about the ventricular interdependence. So how do you measure that? Is everyone comfortable taking? Do you want me to go over this or? Okay. So basically, what I'm trying to say here is actually, let me go show you these things and then we'll go back. So the changes during tamponade. This is the normal aortic pressure. This is early tamponade, very early tamponade. You have some changes in the right atrial pressures. Don't worry about it. It's difficult to decipher, but the Y descent is lost. Okay. But the key is the aortic pressures. The pulse. Look at the pulse pressure from here to here, right? The pulse pressure decreases. The mean pressure also decreases. So that's the first change which happens. You may still not find it because what we normally look at is this pressure, and we think, oh, from 140 it came down to 110. We don't know what's going on. The next thing what you find is hypotension, but there is a significant respiratory variation, right? So when we measure a blood pressure by your cuffs, electronic cuffs, it measures the blood pressure. It can measure the blood pressure here. It can measure it here. It all depends on the timing when it's cycling. If the respiratory rate is very fast, the odds of picking the lower number is high. If the respiratory variation is slow, in the sense it's breathing only 6 times a minute or 10 times a minute, there's a good chance that you may be picking up this pressure. But actually, there's more hypotension than what you think. And if you have this, where actually, if this is 100 millimeters and this is close to 90, there's a significant drop to the extent that there's actually no perfusion, almost no perfusion, no pulse pressure. There is a perfusion at diastolic pressure, but there's no pulse pressure during peak inspiration. And if you use a cuff, the electronic cuff, it's going to pick up this number. What you need to pick is this drop. That's why we need to check this pulsus paradoxus carefully. So how we do it is that we, normally, even if it's reclining flat, that's fine. Respiration should be normal. You don't have to ask them to take deep breaths. Because if you take deep breaths, the normal difference of 10 millimeters is already wider. So you'll have a false positive. Let the patient breathe normally. The blood pressure cuff should be, you get a systolic, whatever your approximate systolic numbers are. If it's 120, go above that, a couple 20, 30 millimeters mercury above that. And then slowly, the key is the slow. And the speed in which you come down, deflate the cuff, should be related to the respiratory rate. Basically, you don't want to miss, you want to catch both inspiration and expiration at every pressure drop. That's what you have to do. So you come down slowly till you start hearing the sounds, the first Korkov sounds, however you pronounce it, during expiration. Because that's, expiration pressure is higher than the inspirated pressure, right? So the first time you'll hear it during expiration. So you note that level when if the curve is not deflated further and this is present, then the first sound is not audible during inspiration. So there comes to a stage where you can listen to that sound, or you can hear that sound only during expiration and not during inspiration. Okay, mark that number and then keep coming down slowly on the cuff pressure. At some point, you will hear those sounds both during expiration and inspiration. the first point when you hear both during expiration and inspiration, mark that pressure. The difference between these two pressure, if it's more than 10 to 12 millimeters of mercury, that's pulsus paradoxus. So basically, inflate the cuff above the systolic blood pressure, come down slowly, make sure that you're listening to the sounds both during expiration and inspiration. If the other way of cheating around it is just figure out if the patient is expiring. If he's expiring, don't drop the cuff pressure if you hear some sounds. If the patient is inspiring, I mean he's taking an inspiratory effort, and you can still hear sounds, then you can drop the cuff pressure. Okay. Because you lose during inspiration. So the key is to find when you're losing during inspiration. Actually, I've not done it for some time, but if you hold a radial artery, feel for the pulse. Just feel for the pulse pressure. As I said, the pulse pressure also decreases, right? If you look at this, the pulse pressure decreases. See, the pulse pressure is the difference between systolic and diastolic is this one, and here is the pulse pressure decreases. So even if you don't even have to do that complicated, blood pressure measurement, you just hold the pulse, wait for the patient to breathe in and breathe out, and see if there is a difference. That's a pretty good screening test. If you find that the pulse is harder during expiration and you can feel it in the radial artery, that means there is a significant blood pressure difference. And then you go back and do the manual measurement to come to the number. And if you find a difference, that's significant. That's very, very sensitive. That's more sensitive than any other things. It's a complicated slide. I'll skip through, but basically it's the same thing. Tricuspid flow, during inspiration there is increase, during expiration there is decrease. This is the trans-tricuspid flow. Mitral flow, during inspiration there is decrease, and during expiration there is increase. So completely opposite. Aortic flow, during inspiration there is drop. Aortic flow and the mitral flow go together. So whenever there is a drop in the mitral flow, there is a drop in the. So this is the respiratory variation. Important thing, there are other things which can cause pulsus paradoxus. Lung issues. Okay, lung issues. If someone has severe asthma, severe COPD, when there's exaggerated intrathoracic pressure changes, you'll have pulsus paradoxus as expected, because some of it is dependent on the respirations. There are so many other reasons why you would not have. Again, most of them are related to two things: severe hypotension. If the blood pressure drops significantly, forget about the respiratory. The pulsus paradoxus is helpful when the blood pressure is normal or near normal. Okay, if it is dropped below 90 or 80, forget about that. You don't even need to do that. Then you have shock already, right? So you don't have to look for the respiratory variation. And if there are any shunts, because they equalize the pressures. Again, there are signs we can pick up on test during the diagnostic studies. You have sinus tachycardia on the EKG, low voltages. Obviously, the voltage on the surface EKG is based on the conduction of the heart electricity to the leads. If there is fluid around it, the conduction is going to come down, so the voltage will be low on all the leads. Electrical alternates, because when the pericardial effusion is big, the heart kind of wobbles in the pericardial cavity, and whenever it does that, with every beat, the QR is bigger and smaller, so that's electrical alternates. And obviously, if the patient had a previous pericarditis, will have signs of pericarditis. X-ray, forget about it, unreliable. So this is the classic example of sinus tachycardia, low voltages, and electrical alternates. Most of the electrical alternates are in the precordial leads. Look for the precordial leads. That's a chronic pericardial effusion, a patient previous CABG, and so patients with CABG also have tamponade. They may not have the circumferential effusion, but they do have tamponade. Echocardiography, I don't know if you want me to go in detail, but basically what you see is an effusion, right? Sometimes the effusion is not present. That is because you're looking late in the course. You see early there is a translucent effusion, but if it is blood, it clots off. And then on the echo later, you may not see the effusion. All you see is there is a space with clotted blood. Clotted blood doesn't look the same as fresh blood, so people may underrate a pericardial effusion in patients who have clotted blood. So that's also an important aspect. Basically, what you find is first thing that happens is the RA collapse during diastole. Diastole collapse of RV, and left side collapse generally the LA. LV doesn't collapse. LV, the problem is not the collapse, but LV filling is decreased. So we look at these things on the echocardiogram all the time. Respiratory variations, so these are the cutoff numbers. If it's normally, as I said, about 25 to 30% change in the tricuspid valve flow during inspiration. If it's more than 50% increase in the tricuspid flow during inspiration, that's classic for, it's the same as pulsus paradoxus, echocardiographic finding of pulsus paradoxus. If it is more than 30% decrease in inspiratory mitral flow, it's echocardiographic finding of pulsus paradoxus. It's the same concept. If you find this happens earlier than this. So even when we don't see any of these signs, that is the chamber is not being collapsed by the pericardial fluid, if you find these changes, it's again a sensitive marker. So this is actually more sensitive than the pulsus paradox. But we don't echo everyone. That's why it's important to do this. So pulsus paradox and this are very sensitive findings. There's abnormal septal motion. This is actually the first thing which happens, but we cannot find it all the time. And IVC. So the IVC, normally IVC, I'll show you a picture. It keeps changing during respiratory movements, and when you have tamponade, it doesn't change. So here you have apical 4-chamber view, LV, LA, RV, RA, pericardial cavity. Obviously, there's a huge effusion. No one misses this. There is a collapse of the RV. Normally, RV is not as big as this, but it should be about at least half of the LV cavity. And it doesn't look like that. And there's a compression of the RA also. So this is probably diastolic. You see the LV is expanded. So there is end diastolic compression of the RA and RV. So it's classic tamponade finding. Here you have effusion. People may call it small pericardial effusion. It's not a big pericardial effusion. Maybe moderate here. Small to moderate. RA looks fine during one phase, during early diastole actually. That is when the RA is filled. Actually, not this is mid diastole. Here you see there's the localized compression. So that's a very sensitive finding. And if it is there, it's actually, that's one of the first changes you can find as far as the chamber collapse is concerned, because RA is the least pressure of all the 3 chambers which can collapse. And so this is the RV. So this is parasternal view, right ventricle, left atrium. You cannot see the right atrium. This is the aorta. If you don't look at this, that's a normal heart. There is no anterior pericardial effusion. There is no effusion here. So you'll say everything is fine, but if you look here, there's a huge loculated, localized pericardial effusion behind the LV. For whatever reason, the effusion was accumulating locally and was causing tamponade. Would have been missed. Normally, this depth is adjusted to look at the heart. If you don't go deep enough, you cannot find it. This is the IVC. Normally, IVC increases during inspiration and decreases during expiration. It's the same flow as the tricuspid valve. The tricuspid flow is higher, it increases. But if in tamponade, it doesn't change because it's already saturated. It's something like the pericardial fluid. It's saturated, dilated, so there's minimal respiratory changes. Diagnostic studies, you have all these things, but if you do cardiac cath, the key finding is there is diastolic equalization of the diastolic pressures of all 4 chambers. So mean right atrial pressure, mean diastolic right atrial pressure, because the diastolic pressures keep changing too. So the mean diastolic right atrial pressure, mean diastolic left atrial pressure, mean diastolic right ventricular pressure, all are equal with the pericardial pressures in tamponade, because the pressure is equally distributed and all of them are compressed to the same degree as far as the diastole is concerned. But we don't do cardiac cath for tamponade to know if we have it or not. So, treatment. There's only one definitive treatment, which is tapping. So we need to do pericardiocentesis. That's the treatment of choice. As soon as we do it, the better it is. In the meantime, obviously, first thing is clinical diagnosis, right? I mean, you have to diagnose it. The single most important predictor of mortality after tamponade is time to diagnose. The longer it takes, we lost time. As I said, we have that last drop phenomenon, few more drops, you don't have much to do. So rapid clinical diagnosis is the key. Once you do that, it can accommodate some extra fluid. But that's not the treatment of choice. I mean, you give some fluid just to buy time. So whatever fluid you give, you're trying to increase the intracavitary pressure. So you're basically trying to increase the right, suppose there is right atrial collapse or RV collapse, you give lots of fluid and the intra-right atrial pressure and intra-right ventricular pressure increases transiently to a certain degree above the pericardial pressure that it overcomes the collapse. So you can buy some time, but that's not going to stand because the pericardial pressure is going to increase more and then overcome that. And that's why if you're giving it few liters, forget about it. It's going somewhere else. Avoid and potential benefit from dobutamine. You can give dobutamine. If you have to think about one, that's dobutamine. Avoid intubation. Key, because the whole dynamics of the respiratory thing is going to get messed up. And you're going to give some sedation during intubation. The peripheral pressure is going to go down. So basically the peripheral vasodilation does happen, which is why you see the blood pressure drop during intubation. And that intubation also causes decrease in the intracardiac pressure. So the pericardial pressures are not being affected and you're dropping the intracardiac pressures. So you're actually causing worse tamponade. So postpone intubation. That's a common thing. Someone is being quoted for pericardial tamponade. If you have the cath lab ready and you're taking him, you're on the way, you intubate, that's fine because it's taking 5 minutes before you tap him. But if it's going to take half an hour to 45 minutes, don't intubate the patient. You have to keep, I mean, it's an ethical thing that, he's not comfortable, or he or she is not comfortable, you have to sedate him and everything. You can give some least vasodepressor sedation. You can give pain equals thing, but intubation or anything which is causing the blood pressure to drop, try to avoid it. And none of emergent pericardicentesis is the way to go. So anything you do should not delay. And obviously you have choices with percutaneous, where basically you just go with a needle, or you can do surgical one. Surgical tab. So surgical tab, you don't need to. You don't need to do that unless and until you are sure. I mean, you are a very high suspicion of causing more damage. So whatever is caused, if it is post-procedural, and you think that there is a relatively large accumulation in a short span of time, or you think something might have got torn, then you take. Or if the lead is a post-procedural, post-implant, and the lead has gone through and through the myocardium, you don't want to tap that patient because you want to do it in the surgical OR to make sure that once the lead is taken out, you may come back again. So, anyways, this is we can make a decision about that as part of the movement, but most of the time we do percutaneous. Even if the patient is going for surgical you can first tap and then take him there. If it's a malignant effusion, this is the common reasons why you would go for surgical evacuation. If it's a malignant effusion, the patient has metastatic disease, it's going to keep accumulating and it's going to be bloody and it's going to clot up. You put a drain, the drain is going to keep clotting, you keep flushing, it's going to keep clotting. The best thing is to create a window so that there's a bigger hole so that the drainage is much quicker and the clotting is less often. And obviously we don't know the etiology of pericardial effusion, not post-procedural, but otherwise, then we can do a pericardial biopsy if you're going for surgery. So summary, tamponade is not uncommon after invasive procedures. One of the most common causes of post-procedural death. Early diagnosis is the key. Tachycardia, CMED, pulsus paradoxus, and hypotension are very special. If you find these things, think about it. Emergent echocardiogram to confirm effusion. Only to confirm effusion. Tamponade is a clinical diagnosis. Okay. Echocardiogram doesn't confirm. It just confirms the diagnosis. It just confirms the effusion. If you find the tamponade physiology, that's basically clinical. You suspect it, and then you look at an effusion, you know that's what it is. Emergent pericardiocentesis with the fluid resuscitation in the meantime is the treatment of choice. I think that's all I have.
The only thing I have to say is if you guys know that there's even a small pericardial effusion or something going on, to let us know, or let your nurses know and report, because there's been a couple of times that they came back and that there's an echo ordered, and we're like, okay, why is there an echo ordered? And then maybe 45 minutes later, you guys come out, or somebody comes out and it's like, oh, they have an effusion, and we're like, oh, that'd be nice to know, just to,
Okay.
you know, because, you know, we monitor for everything, but if we know they have an infusion, it's a lot easier to be a little bit more
Sure,
aware
absolutely.
of that. And, you know, as many redo AFibs that we have and stuff like that, now knowing kind of this, it makes it a little bit more